There we go. Thank you, Angus. Okay. All right. So welcome everybody. We're getting a nice quorum here. It's Tuesday afternoon. It's 3 p.m. There he is, Smokey Joe. I was gonna guess.
What else? But I just wanted to do something that was just off color, that kind of thing, right?
I was guessing just in time, but you got me this time, Smokey
Yeah.
Joe.
So hey, we're still waiting for people. Did you get the transcription today about what our CME is for today?
No, can you tell it to me, and I'll throw it in the chat right now.
Sure, as soon as I find it. And if you don't mind, I'd like to say a couple words about our speaker today that I found out about early this morning. So, which is kind of cool.
Hey, Paul, is that a U2 hack? Because I just won the bet.
Yes.
Yeah, that's from that was from my Asia tour.
Paul, I said it's U2, Stones, or the Police. So
yeah, exactly. I could switch over. I have Steely Dan as well. So I'm sorry. I shouldn't be clowning around. Let me see if I can find the our thing for today. I have to print it out anyway. So Eagles, where is it? Updated. Here we go. Zoom. All right. So today's thing for the Seagulls is 17322. 17322. It'll go on to be 7323 for the full meeting at 3:30. Okay.
So the afternoon one is 17323.
Yeah, same sequence. Yes.
Okay, it's up. All right, awesome. Thank you, Paul. Okay, all right. So let's get started. Welcome everybody. It's 3 o'clock in the Eastern time here in South Florida. Today we have a very special guest. Many of you know Dr. Marc Eckstein, former EMS medical director out in Los Angeles, and he's been doing it for quite a long time. And he came on our webinar. Mark, how long ago was it that you came on our webinar? Probably, it was less than a year ago.
It seems, maybe a year ago. It's been a while.
It's been a minute. It's been a minute. And I know you have a lot of great updates to give us, and I know a lot of agencies in Florida are ramping up with Tele911. But before you get started, Paul, you said you wanted to make a couple of comments, and then we'll let Mark take it away.
Yeah, I've actually known Mark for literally several decades. So first of all, and actually I first didn't meet him, but I was supposed to meet him in 1992. Well, he'll explain sometime later on why he hates me forever. But I got to know about his background, I think, before we get into this. First of all, Mark started off as a New York City paramedic way back in the 80s, et cetera. And eventually went into medical school, did well, ended up in La La Land in LA, and gradually went his way up through the ladder, so to speak, as their medical director over many years. Ended up becoming their bureau chief, actually part of the fire service, and was the bureau chief there for a long period of time. His experiences in post-traumatic circulatory arrest, his experiences in disasters have been enormous, but mostly importantly, he was on the streets, always there responding, got a great family and all that. And also, he was a person that went to 911, and he was part of the rescue teams that went in there later on. He's had an incredible experience and incredible career. And about a year ago, because he thought it was the right thing to do, especially after COVID, he got into this program to try to help offload emergency departments and, more importantly, do the most appropriate thing for the patients and not always you call, you haul. And I've been really impressed with it, and I'll make a comment later. I just wanted to say that Mark's an extraordinary person. We're just really glad to him. And by the way, I should mention, Mark, I think you were the first full professor at the University of Southern California, if I remember. Is that right? In the Keck School of Medicine. Am I right in saying that?
Yeah, well, you're embarrassing me, but yes, but that is correct.
Okay.
That's correct. Thank you.
Now I've left 2 minutes for your talk, so get on with it.
Right, how much did that cost you?
It was like he bought me a cup of coffee one time, and
no, that bought you. I'm going to buy you an Irish coffee after that one. But Paul, thank you so much. And yeah, Paul actually was my mentor and dear friend and colleague now, and Peter and a lot of people on the call. Thanks for inviting me. I'm going to share screen, for a moment. I'm not going to do death by PowerPoint, I promise. But I do want to give everyone kind of an update of where we are, and just kind of open up the Q&A. So As Peter mentioned and Paul mentioned, why we get into Tele911. Everyone really has the same pain points now in EMS. ED overcrowding, the paramedics are burned out, running non-acute, low acuity calls. And, as Paul mentioned, the you call, we haul phenomenon really hasn't changed really since EMS started over 50 years ago. And then on the flip side, at least I found in my tenure in LA, and
Mark, can I interrupt you for a second? One thing I should say also is that one of our problems right now is this wall time or ambulance parking. And you were the one that first wrote the article about how to handle that stuff way back in. So this has like been near and dear to you. And I'm sorry to interrupt you, but it's just like people have to know you've been on top of this for a long time. And I just think it's you have your finger on the pulse is what I'm getting at. So thank you so much. I mean, you've had it on there for years, as you've just mentioned. So.
Thanks, Paul. I appreciate that. Yeah, well, initially we did wrote up a retrospective study looking at wall time in LA. We were losing the equivalent of 3 to 4 ambulances. So we had, 96 plus hours cumulative per day with wall time. Obviously, that would ebb and flow during COVID and seasonal influenza. Paramedics were carrying wall kits with them. I mean, it was just horrific. And then a high percentage of patients for whom they were babysitting on the wall were not, were stable. And then the paramedics would miss critical calls, which obviously compromised lives and were a huge morale killer for the paramedics. Then on the flip side, we saw, because the medics wanted to avoid wall time, often for the right reasons, they wanted to become available, they kind of started pushing the envelope to leave patients at home and not transport them. And we, unfortunately, I'm sure as everybody else on this call has dealt with, we had some really bad outcomes and catastrophic outcomes with some non-transports because the paramedics didn't want to transport. They knew if they transported, they'd be out of service for many hours. And some of these were really tragic. And then on the flip side, patients who need to go to the hospital, the medics are trying to convince, they often refuse. And we know a lot of those tend to be middle-aged, older males. We're all stubborn. The wives call, the kids call. I think all of our medics, a lot of us have seen, even in the ED, the 65-year-old male, he's pale, cool, diaphoretic with tombstones on the 12 lead, and he says, it's just indigestion, I'm not being admitted, or in the field, I'm not going to the hospital. And it's a horrible feeling because you can't convince them over the phone. So we'll talk about that really briefly. So we're really talking about paradigm shift in EMS. And it's interesting. I actually put this up on LinkedIn with an X over you call, we haul, and it kind of went viral, got over almost 60,000 hits on this. So it really struck a nerve that we need to stop the you call, we haul phenomenon. Our telemedicine policies that we have with our EMS partners are really straightforward and when to consult telemedicine. And the biggest bucket really is the medics think the patient's stable, doesn't need to go to the ED by ambulance. They contact one of our board certified state licensed emergency physicians. They pick up the call in about a minute. They do a brief teleconference with the medic and the patient and make a disposition to try to keep the patient at home or free up the ambulance if the patient needs to go for care, but does need to go by ambulance. And then on the high-risk patients, high-risk refusals, and then the patients 65 and older that are not being transported, sometimes those are high risk and some of the red flags may be missed. And I think one of the most important components of EMS that's really been a huge void is patients who are not transported. We're really not addressing their problems. And I think that's something we've really seen. And despite my 35 years experience in EMS, I think the epiphany I had now that we're 1 year operational with Tele911 with multiple agencies is that almost all the patients who call 911, with very few exceptions, really are not calling because they want an ambulance ride to the ER. They're really calling because they want their problem solved. And that statement supported by the fact that of almost 2,000 consults and the paramedics call requesting a treatment in place, there's only about one handful, about 5 or so patients still insisted on ambulance transport after our physicians recommended treatment in place. Meaning they were comfortable to be reassured. The emergency physician walked them through what their impression was, sent in necessary prescriptions, and then that next day follow-up by a patient care coordinator is so important. A, to make sure the patient who wasn't transported is safe. And if it was a high-risk refusal who we couldn't convince to go, that's our highest priority for next day follow-up. Basically do a comprehensive needs assessment. Why does this patient call 911? and link them to primary care and local social services. And this is really low-hanging fruit. And our patient care coordinators have been successful about 85% of the time, convincing patients to go to the ED, which is really quite remarkable. Why they connect them to primary care. So some of the most common EMS transports that we see day in, day out that have led to ED overcrowding and wall time that we're routinely converting to treatment in place. Not surprisingly, cough, fever, congestion, flu symptoms. And I think the trick here is, because we have experienced emergency physicians doing the consult, we're able to tease out those patients who may need to go. Then maybe they're getting septic, they have comorbidities that may tip them over. They have pneumonia that requires inpatient care. We'll look at a 12 lead, but we're keeping patients at home, even at all ages. We've even had patients in their 90s with flu symptoms, even a positive COVID test, a home COVID test that we're able to keep at home, plus or minus Tamiflu, plus or minus Paxlovid, plus or minus a Z-Pak, again, with the next day follow-up. And we know transporting elderly patients to the ED unnecessarily is really a horrific experience for them, and again, ties up our paramedics. Near syncope, palpitations, headaches, back pain. It's amazing how many patients with chronic hypertension, run out of their medications, have some headache, or they monitor their home blood pressure, the kit alarms, they call 911, gastroenteritis, UTIs, a lot of low-risk chest pains. As we risk stratify like we do in the ED, we'll do a PERC score, we'll do a heart score, look at the 12 lead, risk stratify to keep these patients at home. Tons of patients call 911 for anxiety. This was actually one of the most common provider impressions in my experience in LA, where we had catastrophic outcomes. I think the difference here is having the emergency physicians work with the medics on scene to risk stratify, and then determine how these patients need to be medicated and send in prescriptions to really treat patients in crisis and make sure the anxiety is not something that suggests underlying serious pathology. Febrile seizures, we know that's terrifying, particularly for first-time parents, or first time the parent has an infant with a new onset seizure. And if the kid is well appearing, back to baseline, the vaccinations are up to date, we're routinely keeping these kids at home. Known asthmatics and COPDers with no significant comorbidities who turn around after a DUNEB. Some of the paramedics, particularly in Florida, carry steroids, some carry magnesium, and keeping a lot of these patients at home, refilling their MDIs, calling in prescriptions for antibiotics and steroids, and doing next day follow-ups. The patients are thrilled not to have to go. We also know a lot of the skilled nursing facilities now, because they're so risk averse, they're telling their staff to call 911 for anything and everything. And we know it's a really horrific experience for a resident of a nursing home or skilled nursing facility to go to the ED in that chaos. It's just a horrible experience. It exacerbates dementia and so forth. And we're keeping a lot of these patients in their residence at the skilled nursing facility when it's appropriate. Known renal colic, recurrent seizures back to baseline, and a lot of med refills. So these are just some common complaints that cumulatively, I think, are really running the EMS system and the ambulance and the paramedics into the ground, causing ED crowding, wall time, that we're able to keep patients at home. And the patients are absolutely thrilled. And the medics are happy because they don't want to transport. On the other side of the spectrum, in terms of high-risk refusals, there are a few that have come to mind. And these are just consults I personally handled, where it's really gratifying when the medics will do a consult and say, "Hey, doc, we have a high-risk refusal." Patients adamantly refusing to go, and most of these were able to convince within a few minutes. We actually had a patient with a dense hemiparesis with a classic large vessel occlusion. It took probably 20 minutes to convince him to go. He actually still got a thrombectomy. I've had some high-risk TIAs with motor deficits, convinced them to go. ESRD with pulmonary edema. A lot of vague complaints where paramedics may not transport. Middle-aged patients with CAD, hypertension, or just diabetes with some cardiac risk factors, just feel weak, dizzy, nausea, fatigue, near syncope. Look at the emergency physician looks at the 12 lead, points out the concerns to the paramedics, convinces the patient to go to get transported for risk stratification. Shock, We actually had an unfortunate woman who was actually in hemorrhagic shock from a second trimester SAB, who adamantly refused to go with paramedics and a field supervisor, and our physician was able to convince to go. So these are really gratifying. I think the difference is, and I think like everyone on this call, I've taken hundreds of refusals over the phone. It's very difficult, if not impossible, to establish a rapport with the patient and their family without video. And I think that's really the difference. And just explain very straightforward, hey, I'm an experienced emergency physician. Here's what's going on. Here are the diagnostics and therapeutics you need. These are the likely consequences if you don't go. Engage the family. And we've been incredibly successful convincing patients to go using this format. We're currently now in California, Florida, and Texas. We're scaling very rapidly this year. We'll be expanding to multiple other states as well. We started in South Florida, and we've had great success there. In terms of just overall metrics, so we've done about 2,000 consults. About 86% of the time when the paramedics request a treatment in place or no transport, our physicians agree. And it's really shared decision-making. All of our physicians, I personally have vetted, these are all experienced emergency physicians, a lot of whom have EMS experience, and the patients feel empowered. We always say they have the medics, are you comfortable with this treatment? Are you comfortable giving Toradol or another breathing treatment, or are you given IM intranasal ketamine for patients with severe pain? Is the patient comfortable, the medic comfortable, and everybody's happy? On the flip side, compared to one agency, large agency in Texas, where their policy was the medics have to call out a district chief who had to respond in person for these high-risk refusals or AMAs. With a Tele911 consult with our physicians, we had a 600% higher rate of convincing these patients to go to the hospital, and those were literally lives saved. In terms of metrics, we know time on task is important. Our average time to get a physician to answer a consult is running about 60 seconds, maybe about 90 on the night shift, but about 60 seconds overall. Many of the consults are under 10 minutes. Most are under 15 minutes. And again, our patient care coordinators have been successfully contacting patients for next day follow-up 85% of the time. So these have been huge game changers. We have a very large partner in Central California where it's fire department, first responders, private ambulances do the 911 transport. The private ambulance company was so overwhelmed, they were spending $300,000 per week to have other private ambulance companies from all over the West Coast come in for mutual aid. And because of the call load and wall time, we're able to significantly help improve the unit-hour utilization and reduce response times. We're currently covering a little over 2.5 million lives, and we have about 60 million in the queue this calendar year. What we found really is, it really is paradigm shift. Everybody knows change in EMS is never easy. We tell everybody on our team and all our physicians that our primary stakeholders are really the paramedics. The patients really, again, as I mentioned, the patients just want their problem solved. They don't want to go to the ER with very few exceptions. And patients who refuse to go, who need to, we're very successful convincing them to go, which is really gratifying. That next day follow-up, I cannot overstate how important that is. I'm not aware of just about any fire department or EMS provider agency that has that in place. The number one problem they solve is they ensure the patient who wasn't transported is still safe, answer their questions, did they get their prescriptions, and then do they have a primary care doctor? Can this person help make a referral and link them to social services in the community, which is hopefully will decrease further medically unnecessary 911 utilization in the future. I think this is improving morale for paramedics who are really overwhelmed right now, and really helping to really transform a system that's really been overwhelmed and hasn't really changed for many, many years. So I'll stop at that, open up to questions and discussion. And again, thank you.
Okay. Hey guys. Okay, I got it. Okay, thanks. Mark, sorry, I was just taking a phone call. Actually, that was Dr. Shepke, who unfortunately has to step away. But he wanted to have me relay the message that he's a huge fan of what you're doing, and he's a big believer in this, and he's going to continue to work to make this happen across the state. I, for one, am very happy with the fact that you came here with that data that you presented with. I think very powerful. I'd like to open it up to those in the crowd who, we have a lot of people here. This is one of the most people we've had on our webinars in a while. So it's clearly a topic that people care about. So first let me go to Dr. Lee, who has his hand up. Wayne, go ahead. Wayne, you're on mute.
Yeah, I know
There you
my
go.
phone's ringing. I'm trying to get off my phone. Sorry. Mark, excellent. I've been around for a long time, and I'm currently the medical director for the Seminole Tribe in Florida, and I do high-risk refusals, so I get called fairly commonly. We have two constituents, the people out of the casinos, which we have a lot of, and then we actually have the tribe. We are fortunate regarding the tribe in that we have our own healthcare department. So in fact, when I talk to a patient, we have a refusal, then we notify our healthcare department. They follow up the next day. So we're lucky in that, and sort of not a perfect model, but very similar to yours. My question to you is this a contractual relationship, and can you explain that a little bit?
Yeah, Wayne, thank you so much for your comments. Yeah, so we contract with the municipality, the fire department, or the EMS agency. It's a letter of agreement. We don't charge them for our services. We bill the insurance, patient's insurance. And the agreement just stipulates, we take on the liability once we're involved, whether it's a refusal or treatment in place. We'll attempt to do the next day follow-up. So it's a very straightforward letter of agreement. This has gone through, I don't know how many city attorneys, county council, but yeah, so the agreement typically is with the provider agency, which typically, again, is either a fire department or a single function EMS provider agency.
Hey, one of the things I'd like to mention about that, Wayne, is that one of the things I was really impressed with Mark's group's program is that part of the contract is that they take on the responsibility if the physicians take on the responsibility, which, that always bothers me because sometimes when that patient is high risk and they're refusing, assuming that's really the case, that's another thing, but that later someone else will come back, whether it's the family or whatever, saying we didn't explain it enough or whatever it is. So I think that's what's pretty cool here because it's a kind of I think a liability reducer for the agencies. That's why I've really kind of liked this myself.
Yeah, I like I have that same fear on a regular basis, and so at any rate, I think I've heard that answer before. I didn't realize I didn't put two and two together, but thank you very much, Mark. I enjoy that, and I think you're right on target. I agree.
Wayne, thank you for that. I also will add, the other thing a video brings to bear is that situational awareness to determine capacity. I had medics call me for a high-risk refusal from an elderly gentleman with weakness, and he was talking coherently like you and I are talking right now, GCS 15. But when I actually looked at the patient, this patient looked awful. He was supine in bed. And I said, sir, could you sit up while I talk to you? He says, I can't. I go, why not? He goes, I'm too weak. I said, well, how are you going to eat? Well, my roommate will feed me. I go, okay, thanks. Told the medics, I don't think it's the patient's capacity. Do you agree? Yeah, we agree. And we shared decision-making. They gave him two of her said, transported him. I actually took a consult with the same medics 2 days later. Hey, doc, that patient had AKI, dehydration, and was conserved. Without seeing him, I would have said, yeah, sure, he could refuse because he sounded, he was A&O, but I had to, it's just, you can't, EMS and emergency medicine to me is 99% visual. And we've been operating blindly over the radios and telephones since the 70s.
I actually made note of your video comment. That was enlightening to me, and I think a very good point. Thanks.
Thank you,
Russ. Awesome. So let me hold on, Paul. I want to see if while you're going to make your comment, I want other people to raise their hand. We have Jane Bedford, has done a lot of work in this realm, and many other people on the line. So if you want to raise your hand, or Jane, are you available to unmute yourself and give us an update from your perch?
So right now we're working with 34 rural counties. We've got what we call the HELPS project. And as you know, we're trying to implement community paramedic programs in those areas. This is a specifically rural agencies grant. So if Dr. Eckstein could talk to what he does for the rural communities, that would be great. But we're just starting in that work right now.
Yeah, let me comment. Jane, first of all, nice to speak with you again. It's been a minute since you and I last spoke. So I think probably, let's see, we're in Walton County right now. It's a great agency. Probably most of the calls we've got consults with their community practice paramedics. Their CPP program has gotten quite a bit of recognition. We're also operational in Franklin County, which is extremely rural. So we're not urban centric. Because we know that if an ambulance transports from a rural area, their turnaround time may leave a huge swath of the community uncovered for many, many hours. So the different value prop, but again, we're not exclusive to urban or suburban communities whatsoever.
And the value for the rurals is just phenomenal. You mentioned Franklin, their turnaround time is 5 hours. 5 hours.
Wow.
And 30% of the rural communities in Florida do not have hospitals in their counties. So that kind of paints a picture for you.
That's insane. Wow. That's a huge value proposition. Let me bring in, first let me bring in Carrie, and then I see Kim's hand is up. Carrie, you want to make a comment? Oh, you just wanted to, because you came up on video. Okay. All right.
Oh, no.
Okay. Kim, you're up.
Okay, hey, yeah. So as one of the Tele911 physicians, I can tell you it's the ability to help these paramedics to elevate their skill level in terms of, the physical exam. When you have a paramedic at the bedside and I'm virtually present and I can direct and have these paramedics help me do an in-depth exam on these patients, it really does add to the paramedics' kind of experience and that ability to look for things they don't routinely look for. For example, I had a paramedic identify a tender preauricular lymph gland on a child that had an earache before, and they had never thought to evaluate for that, but they were very impressed with the fact that they were able to identify that. So having these paramedics to actually engage in fairly in-depth physical exams, similar to what we do in the emergency department, it really helps to boost their morale and their encouragement. And then from a physician's perspective, when I enter a room virtually, it's like walking into the emergency room and the patient's on the bedside. I mean, it's just the fact that we're separated by a computer, but I still present myself and examine these patients as if I were in the emergency room examining the patients, and I make the same decisions. If I feel I can treat the patient in the emergency room and discharge them home, then I can treat them virtually in their living room and discharge them home, right, of the same prescription that they may be waiting 4, 6, 8 hours in the hospital for. So from a physician's perspective, I enjoy the practice of medicine through the Tele911 system, and I enjoy the reaction of the paramedics when they get to engage in sort of a higher level of patient care than what they would routinely be involved in.
Great comment.
Yeah.
Thank you, Kim.
Yeah, and I want to say Kim has done a phenomenal job given his bedside manner, his decades of experience with paramedics and emergency medicine, and just a phenomenal job. Thank you, Kim.
And so we only have a couple more minutes, but I know that I want to highlight other kind of innovative thinkers. Dr. John McPherson's on the line with Brevard County, who now Paul and I are very blessed to be working with. I know John and Orlando Dominguez are moving towards getting Tele911 up and running in our department there in the next couple of months. Dr. McPherson, did you want to make any comments while we have you? Probably caught him off guard. Oh, nope. Okay. Any other people on the call who want to raise your hand, make a comment, ask a question? I see we have a lot of great people on the call today.
No, adelante.
Adrian, you want to make a comment?
No, I'm sorry about it.
Okay, that's okay. All right. Well, Mark, it's 3:29, right on time. Let me have before Dr. Pepe's got to go. Paul, you want to make any last comments, and I'll give Mark the last word.
So the only thing I would say is there's so many other things I want to say. Like Kim I thought that was really great. I know Kim is actually, Kim and Wayne always have great comments, and they're always, they have such great intuition because they're in there doing it. And so one of the things I was going to ask Kim about, Kim, you actually, I think, because you told me you wanted to do something like this like 10 years ago, okay? And so why is it you didn't develop your own program? Why did you choose this? Because it was turnkey for you, or there other aspects of it that you liked that really amplified what you wanted to do?
Well, 10 years ago, when CMS was putting out the innovation grants, I had applied for one of the innovation grants, and my application was EMS telemedicine. And I went out and did the research and found, companies and equipment that would allow me as a physician to connect with patients in the home. And I guess it all started from me responding on calls as an EMS medical director, standing in the back of the living room and watching our paramedics engage patients and scratching my head and thinking, man, I can't believe you called an ambulance for this. And I can't believe you're going to let them take you to the hospital where you're going to spend 4, 6, 8 hours, and you're going to walk out of that hospital with the same prescription that I could write for you right here, right now. So that got my gears turning to develop an EMS telemedicine program. And I put in for it. I made it through 2 cuts of the grants, and then we didn't make the final cut. But then there was no reimbursement for it. So we had to shelve it. And then along came COVID, and all of a sudden it was a reimbursable project. And by then I just did, I never took it off the shelf and dusted it off. But then we have a great product like Tele911. Thank you, Mark. And that's the story.
Okay.
Awesome.
Well, I'm switching
Awesome.
over.
Thank you. Yeah.
Okay, that sounds good. It sounds like they're ready, waiting, and able to help you. So I like that thank you for bringing up the issue about the rural thing. That's what I wanted to bring up. I wanted to talk
That's
about.
huge.
Okay. All right.
Yeah.
Over. I'll see you guys later. See you on the other side. Bye-bye.
Okay.
Thanks, Paul.
Awesome.
Okay. What
All right.
was 17322 for you guys? See you later. Bye-bye.
Bye, Paul.
See you. Awesome. So yeah, let's wrap it up. But I think for me, what I learned after hearing Jane's comment and that 5-hour thing, I mean, obviously we don't have those issues here, but much of Florida is rural. And for the resus academies, we've been out there, and I remember visiting these fire departments thinking, how do you guys function in a way that's beneficial for your community? And it sounds like they can. So but that's why we have Jane at the helm there. So thank you, Jane, for that. So Mark, let me give you the last word, and then we'll pop over to Paul's side.
I just want to say thank you. I appreciate your friendship, first of all, you and Paul, and friends and dear friends and colleagues, and for inviting me to this opportunity to update you where we are. We're looking forward to expand to other areas in Florida. On a personal note, I feel like I'm like, to Kim's point, I'm virtually in the living room with the patient and the medics. And interacting with medics all over the country is just an absolutely phenomenal experience, which I really enjoy. And again, thank you for the opportunity. I really appreciate it. Thank you.
Awesome. And just for everyone's knowledge, I decided after coming back from NMSP that we were going to make February just kind of people like Mark. Last week we had a Vive. This week we had Tele911. Next week we're going to have Compact BVM. Safe BVM, etc. Pulsera will come at the end of the month. So I think that there's so many people doing very hard work. And the only thing I ask for people is bring the data. And Mark, you did that today. We really appreciate it. Keep up the good work. I know it's hard, but you're the guy, in my opinion, to do this job. So thank you for what you're doing.
Hey, it's a labor of love. Thanks so much, guys. Appreciate it.
All right, everyone. So Angus will take us over to the other side, as it were.